I'm Heather Gotham, Director of the MHTTC Network Coordinating Office, and appreciate you joining us today for our internal TTC learning session on learning collaboratives. Learning collaboratives are something that most all, I think, of our centers have used or planning to use or thinking about using. They're certainly one of the main intensive technical assistance strategies that we have at our fingertips in the TTC networks. And in the past year, the MHTTC Network Coordinating Office collaborated with the Annapolis Coalition on the Behavioral Health Workforce to do a review of learning collaboratives. And today we're going to hear the results of that review. The review includes literature review and search, as well as some amazing key informant interviews. Our speakers today are Michael Hoagie and Manuel Paris, who are with Annapolis Coalition as well as at Yale University. And I think without further ado, I'm going to have Michael introduce himself further and get us started, but we're excited to have you all here. We will, so now there is further to do, but just for a second. Excited to have you all here and learn more about learning collaboratives, how we can make them more effective and have a greater impact on the folks that we serve. And we'll be looking forward to a great discussion afterward. So maybe about 40 minutes or so of presentation, and then hoping for some lively conversation amongst all of us as we're taking in this new material. It's also posted on our MHTTC website, and I'll put the link in the chat here in a minute. Thank you very much. Let's get started. Michael.
Good day, everybody. It's great to have everybody with us. And this project was undertaken specifically to develop some resources for TA providers and to help them fulfill their mission of accelerating the adoption of evidence-based practices and of improving the training of the workforce. And one of the things we hoped to do was to resolve some of the confusion that surrounds the concept of learning collaboratives. We poured through about 600 articles, and we were fortunate to have 17 experts from around the country participate in key informant interviews, and we are enormously indebted to them for the time and the ideas that they shared with us. There is actually a very clear origin story for learning collaboratives. Building on the work of a couple of other groups, the Institute for Healthcare Improvement launched breakthrough series collaboratives in 1995. And the concept was to achieve quality improvement through evidence-based practice adoption. And there were some pretty clear elements to this breakthrough series model. It involved selecting a specific topic that everybody participating in the collaborative would focus on. It involved selecting a group of expert faculty who would then identify the best practices that were to be applied and to assemble them in what became called a change package. These were the strategies that were provided to organizations to implement to achieve their quality improvement goals. The model involved selecting agencies to participate, which would then create multidisciplinary teams that would work together in the collaborative, and to educate those teams using learning sessions. These were all face-to-face in the early days, and there would typically be at least a learning session in person at the beginning, middle, and end of a collaborative, and then providing ongoing technical assistance to the participating agencies in between those in-person sessions. The other element involved data collection through what was frequently called PDSA cycles, the Plan, Do, Study, Act cycles, in which a change would be implemented and the outcome of that change would be studied, and then the change process would be modified based on the data collected and the findings from that experience. And sharing, interagency sharing and learning, sharing best practices, sharing horror stories, sharing challenges, and ways in which they were overcome was also a hallmark of this process. Over time, there were some additional elements that were identified. These occurred through some theoretical analyses and some empirical analyses of collaboratives that were in operation. And some of those other ingredients are a focus on pre-work. So much more of an emphasis on getting agreement with agencies upfront about the nature of their participation and their responsibility, helping them assemble teams, asking them to do preparation before the in-person meetings even began, which might involve collecting some data. Another major theme that has emerged is focusing on the leadership of the agencies that are involved, doing outreach to them, getting them involved in the process rather than them just sending teams to the collaborative experiences. Greater and greater emphasis on email and web support between meetings. Recurrent theme is the difficulty that agencies have in collecting data. So there was a greater focus emerged on providing external support with data collection. Some, but not all, of the collaboratives involve training of staff in the agencies, either by the team that's involved in the collaborative or by the experts that are leading the collaborative. Some of the best analyses of elements were done by Nadim over a couple studies in the 2013, 2014. And she also identified length as a critical element or dimension of collaboratives. When collaboratives began, they were typically about 2.5 years in length. And they've been streamlined as time has gone on. And IHI typically plans collaboratives to occur over a period now of about 18 months. The uptake around the learning collaborative concept has been really quite phenomenal. The concept of learning collaboratives were really widely disseminated and adopted not only in the United States, but around the world. There were European countries that have centralized health systems that use the learning collaborative concept and BTS model to implement changes across their entire country in particular areas of quality that they were concerned about. With adoption also came adaptation. So people started playing with the BTS model and altering it in various ways. One of the cool things about this is that the model has been publicly available and that there are an enormous number of resources that are available to support organizations that would like to learn about and use learning collaboratives effectively. IHI offers an organized college, an extended period of study for professionals about how to conduct learning collaboratives. It has an open school, which is a series of individual educational experiences that you can participate in. It offers conferences around the world on all different kinds of topics. It has coaching programs that will teach individuals how to be better coaches of organizations around performance improvement and quality improvement, and lots of videos and publications and white papers as well. It's really quite phenomenal that they have fostered over 1,000 chapters around the world, which are groups of people who have specific interests in common, who work together on quality improvement topics. And they're just shy of 1 million people have participated in their educational programs. Our sense is that one of the things that's responsible for its success is that the model is sort of elegant, but also at the same time simple. It's fairly easy for people to understand what the elements are and how they come together to create a quality improvement process, interagency process. And so it's resulted in actually a lot of enthusiasm for quality improvement, something that's not always easy to generate enthusiasm about. Sometime in the late 1990s, I was on a flight, I believe, to Atlanta, and I struck up a conversation with the woman next to me who had just come from a Breakthrough Series collaborative. I have no idea what the topic was. I don't remember that anymore. But she was so excited. She was so energized. It reminded me of some of the people that I've met who have come from religious retreats, who are just filled with energy and have made strong interpersonal connections with others around something that's important to them. So again, this is, I think, something that, that is to be noted, the sort of ability that this model has demonstrated to generate enthusiasm amongst healthcare workers for making change. So there are lots of sources of confusion around learning collaboratives, even though it has a very clear origin story. And we've been able to sort of identify at least 5 of those sources. The first is that people use terms without really defining them or providing a description, and that they can use them quite loosely, which has led to some of the confusion. A second source that's been well documented in the literature is that even when people are careful about implementing comprehensive learning collaboratives and studying their effects, they do a relatively poor job of actually describing which elements they used and how they used those elements. So it's often unclear what the collaborative actually consisted of. With the press of time and economic constraints, collaboratives over time have become shorter, less intensive, and have become more virtual, and in a few occasions sort of completely virtual before the pandemic, which has created, again, sort of more variation and more confusion. There have also been some explicitly planned departures from the model. IHI itself has a version that they use when the evidence base is not actually clear in a particular quality area. So they'll acknowledge that it's not clear. They'll still bring agencies together to work on a topic, but they'll be upfront about the fact that the process is about trying to develop some best practices that can be tested and to contribute in the literature while still improving the quality of care in the agencies that are participating. Sometimes dollars are inadequate to fund a full collaborative. Sometimes decisions made that participants, the agencies of interest, don't have the capacity to participate in a full collaborative. And sometimes the goal is just different. It's not about organizational change or system change. And we'll talk about that a little bit more in a few minutes. The other source of confusion is that some people have argued that collaboratives are about quality improvement and are distinct from evidence-based practice implementation. And we just don't think that's true. There are many examples of the learning collaborative model being used in combination with major initiatives to train clinicians or other staff in those agencies in specific evidence-based practice models. And so this distinction that's been made is an artificial one, and again, sort of contributes to the confusion. So to some extent, we have what we have to think of as an urban dictionary for all the terms, meaning that, you know, like an urban dictionary, tons of people are coming up with their own definitions and trying to define concepts. And this is our way of thinking about some of the terms that you'll frequently encounter. A quality improvement collaborative is a term that's often used at the broadest level to capture the notion of these collaborative efforts to change the quality of care. I make the analogy here to the way we think about pharmaceuticals and drug classification. So this would be the class. This is like talking about antidepressants, for example. But then we have the brand level, and the Breakthrough Series Collaborative is a brand promoted by a specific organization defined in particular ways. Another brand that you might think of would be Niatex, a very well-known quality improvement collaborative approach that has been very dominant in the substance abuse area. Over time, we've moved to a more generic term, and learning collaborative is probably the most common term that you see in use to describe these types of models. Again, there's variation in its use, but it is most frequently used in behavioral health, which is one of the reasons we chose to highlight it as the term that we use overall in the review that we conducted. So moving down the ladder here, the model I described that IHI is using when the evidence base is not clear, they often call a learning and action network. These things at the bottom here might be the equivalent of the over-the-counter types of pharmaceuticals, the things where maybe there's a few less elements or a little less potency. So that's the Learning in Action Network, sometimes called learning networks. But then we move to things that historically have been very different, but where the terminology has often sort of been confusing. Learning communities emerged from the field of academia and education, and they literally were groups of people who would get together to study a particular topic, often in the context of people who were together in classes. This term has evolved and been used in healthcare and is sometimes confused with the classic, BTS learning collaborative model. But it has a different origin and is slightly different. And I'll say a little bit more about that in a second. The other concept that emerges is the community of practice. And this term actually had historically absolutely nothing to do with healthcare. It emerged out of social psychology and anthropology and was a description of a notion of people who had any kind of shared interest wanting to come together. And by working together to develop their skills or knowledge in a particular area. It has migrated into healthcare. There are publications on communities of practice in nursing, for example, of nurses coming together to study and increase their skills in specific areas. In terms of learning communities and communities of practice, they tend to be less agency and team-based and more individual-based in terms of participation. They're probably less focused on evidence-based practice packages and more focused on best practices. They're less about agency change and more about individual development. And they're more about learning and less about data. And they're not the type of thing where you would typically find a PDSA cycle, for example. Now I say all that and again come back to the caveat, which is people use these terms in many different ways. So there are no perfect definitions. But these are sort of our efforts to try to bring a little bit of clarity to the concepts. So what do we know about effectiveness? There is evidence, albeit imperfect, that comes from general healthcare, not from behavioral health, that the Breakthrough Series collaboratives definitely have impact on provider practices and also on healthcare outcomes. The evidence that we have comes from the most recent systematic review of learning collaboratives, which was done in 2018 by Wells. We have some high quality individual studies that have been done that provide evidence. And there is some related evidence that would suggest that quality interventions that have multiple elements, like learning collaboratives, tend to be more effective than single element interventions. The imperfections in the research are significant. There are imperfections in terms of the methods that are used in the studies. There's the problem I mentioned before of inadequate descriptions of what's in the learning collaborative that's being tested. And so those are things that haunt the evidence base. There is evidence and there's very strong agreement amongst the professional experts that learning collaboratives relative to things like lectures, workshops, and webinars are more likely to have an impact on what providers actually do and on healthcare outcomes. Despite all the interest that exists in this area in trying to understand which elements of collaboratives are most important, and there's been a fair amount of research on that, there's not a lot of consistency in the findings, and so it's been very difficult to draw conclusions about which are most important. So we come to behavioral health, and there really is widespread use of learning collaboratives in this field. In the appendix of the report, we've documented hundreds of articles that have described sort of their application in behavioral health. But there is not a very strong evidence base. There are not enough great studies to be able to evaluate the impact of collaborative behavioral health. This is an issue that sort of, I think, haunts us in a lot of areas. And my sense is we're left to sort of draw on the findings that come from general healthcare, as opposed to having a sufficient amount of evidence in our own area to draw conclusions about overall effectiveness. So amongst all of the applications in behavioral health, we've tried to highlight some of the areas where the application has been really phenomenal. The Child Traumatic Stress Network, which is managed by the National Center for Child Traumatic Stress, uses the Breakthrough Series model for large systems change and what it refers to as learning collaboratives for EBP implementation, mostly in the trauma-focused CBT area. But in addition to the implementation, they have a very large network of centers and affiliates that is ongoing that they use in order to promote sustainability. And they've been very novel in that they've launched an effort to train their member agencies to be able to lead learning collaboratives as a mechanism of spread of trauma-focused care across the nation. Here in Connecticut, CHDI, Local Technical Assistance Organization, has not only done the trauma-focused CBT, but used the learning collaborative model for a whole array of evidence-based practices. The state has funded them to support an ongoing network of agencies to participate in this EBP implementation and quality improvement. And they collect data centrally and have argued that having a data repository that demonstrates on an ongoing basis that children in Connecticut are receiving evidence-based practice services has resulted in the sustainability of funding for those services across the state. The National Center for School Mental Health implements learning collaboratives across the country. They're very big on the PDSA cycles as mechanisms of change. They're very unique in that they use the collaborative model to bring together educators in the school system with the mental health system. And a number of applications have been, of collaboratives been used for that kind of cross-sector integration and quality improvement, including in the sort of child mental health and child welfare integration efforts. The school-based efforts are also particularly notable for their centralized data collection nationally and the dashboards that they provide to districts. There's been a lot of work on behavioral health and primary care integration. The National Council did a fairly well-known study in this area, although it was observational. Many others have done collaboratives on this. It's noteworthy that the National Council has sort of moved away from doing classic BTS-style learning collaboratives, and doing much more in what they would refer to as learning communities, where organizations are coming together to sort of learn about concepts, learn about practices, and maybe develop a plan related to them, but not necessarily to sort of do a full implementation of those practices. Very noteworthy effort related to behavioral health was conducted by IHI last year. They created a learning and action network on improving behavioral health care in EDs. This is a huge problem for us across the nation. They recognize there's not a good evidence base, but they brought together experts to begin the process of having systems work together to identify and test best practices that could be used by others. The IPS learning community, which is focused on supported employment, is another fascinating example. Debbie Becker, one of the leaders, describes that this was not intentionally designed as a BTS-style learning collaborative, but there ended up having almost exactly the same elements for their initial wave of going into states and implementing their supported employment model. They pair that with an ongoing network that now has 24 states and 6 countries, and again, common centralized data collection. And their data on the sustainability of effects from this collaborative and then ongoing learning community process, they sort of combine the two, are really quite strong. I would say in that regard, if you look at the child trauma school-based effort, the IPS model, their emphasis on sustainability is something that really is missing in the original BTS model. There are elements of the BTS IHI model that focus on sustainability, but the activities really end when the collaborative is over. And so this focus on sustainability is something I think that's very important for us to attend to as we're looking at the ultimate sort of quality improvement initiatives. Last but not least, Niatex, which I mentioned earlier. This was developed by Dave Gustafson and others at University of Wisconsin. He was also involved in developing the initial IHI model. With its focus primarily on substance abuse, it also is heavily into PDSA cycles and has demonstrated its impact on things like access to care, wait times, and retention. So I want to turn things over to Manny, who's going to tell you a little bit about best practices and some of our findings on health equity. Manny?
Awesome. Thank you so much, Michael. Hello, everyone. So happy to be on the call with you and to be able to share this information, the findings from our report. So I'm going to start off with best practices. So a number of best practices around learning collaboratives were suggested by key informants that were interviewed and derived from the deep literature scan we conducted. For example, interpersonal interaction, with the process of people learning and sharing together, is considered by many experts to be the cornerstone of learning collaboratives. Experts recommended fostering interaction for a variety of reasons, such as to create motivation and an expectation that this will be a productive endeavor, for social and peer pressure, for accountability, and to foster a group within which people can discuss the challenges, get new ideas, and benchmark progress. In-person events have been the prominent way interaction has been catalyzed through such things as meeting discussions, breaks, happy hours, and social dinners. Of course, now the pandemic has forced everyone to go virtual, as we are today. So the new challenge is to use virtual platforms to create meaningful interpersonal interactions. And experts were enthusiastic about the ability of virtual collaboratives to do such things as decrease cost, decrease burden on provider agencies and their participating teams. It also greatly increases the number of people who can participate from agencies, from around the country, and even from other nations, all the while decreasing the environmental impact of collaboratives. On other topics, experts emphasize the importance of communicating clear expectations to collaborative participants, having written agreements between participants and collaborative sponsors, helping agencies select team leaders for the collaborative who have real influence in their agency and a good connection with the CEO. Having that open line of communication is really key. Including persons in recovery and their families in the planning of collaboratives, in agency teams, and among collaborative faculty as well. Additionally, using data, but really keeping it simple and measuring just a few things that are practical to track so as to not overwhelm the process. A few more areas that were emphasized include engaging leaders by focusing on topics that are of great concern to them, or what one expert has called the rocks in their shoes. Understanding and honoring the world in which participating agencies exist, and thus maintaining realistic expectations. Accepting the variability in capacity among agencies and examining how agencies can support each other. So those agencies that may be farther along in the process can support those other agencies that may be struggling. Not allowing passive participation and instead insisting on engagement and participation early on in the process as a way of building enthusiasm for what lies ahead. And for me, the most important best practice that was articulated is to foster fun and laughter throughout the collaborative process. You cannot underestimate the power of having a good time while engaging in serious work. It is an excellent way of creating a culture of cohesion. The second point that I want to talk about, if Mike, if you can move the slide over, is around health equity. So this is a very important area, but it is one that really gets little attention on matters of when it comes to talking about health equity in general healthcare or behavioral health, despite the fact that we know it is an area that is important to all of us. So now the IHI has published a white paper titled Achieving Health Equity, a guide for healthcare organizations in 2016. This document provides guidance on how healthcare organizations can reduce health disparities on multiple fronts. Based on a review of the literature, interviews of experts, and site visits to standout organizations, this document offers a framework for agencies to improve health equity. Additionally, an exciting development has been this month's launch of the IHI's Pursuing Equity Learning and Action Network with Health Systems. This is IHI's first collaborative focused explicitly on this topic, and its goals are to underscore the urgency of eliminating inequities, provide improvement methods and tools for testing and learning solutions, and create a network for sharing learning across organizations to include disseminating results, challenges, and effective improvements. The experts that we consulted with have suggested numerous best practices to include considering the impact and implications of diversity for every aspect of the collaborative. So as an example, allow informal video applications from safety net organizations as an alternative to more formal and daunting written applications. Including people who are affected by inequities in planning the collaborative. Those lived experiences are vital to effective implementation. The importance of developing trust with the community and its providers, which has suffered from inequities related to having mental illnesses and being diverse. Now, of course, we must realize that this may be a process that takes a long time in order to gain that trusting relationship. Using a phased approach that begins by examining the cultural determinants of health among the population served by agencies in the collaborative. Now, these determinants can include language, social integration and inclusion, cultural identity, and culturally based practices and values. Always setting a goal of improving the connection of individuals to their communities. That sense of connectedness can help improve health equity. And finally, using collaboratives to support and provide role models for professionals from diverse backgrounds who are serving diverse communities. Learning collaborative faculty who are from the diverse population of focus can serve as a powerful role model for professionals from that population.
Thanks, Manny.
Thank you, sir.
So you'll find in the report sort of a list of the findings, which are, we've covered sort of many of them, but the also thing in the end of the report is we tried to distill some recommendations. And as we began to ponder these, some of them seem to clearly apply to all aspects of technical assistance, while others were more specific to collaboratives. In terms of those that apply to all aspects of TA, the first recommendation is to adopt a framework for clarifying goals and strategies. IHI brought to our attention something called the Kirkpatrick model. It's been around for a long time. It was developed initially and is used still currently for evaluation, a framework for evaluation of training. And it basically suggests that you ask, what is your objective with the particular training or technical assistance initiative that you are about to launch? Is it about participant satisfaction? Is it really about imparting knowledge, skills, and abilities? But a third level, is it about achieving behavior change amongst the participants? And in the fourth level, is it about results? In our case, looking for changes in healthcare outcomes. And IHI uses that, clarifies its objectives, and then goes and looks at the strategies that they will use for their initiatives to achieve those goals. The second recommendation is to ensure that improvements in healthcare and health are among our goals. All of the experts and much of the literature talked about the ability of things like webinars and lectures to impart knowledge, to change attitudes, to catalyze interest in a particular area. But we must make sure that there is some balance and that a sufficient amount of our work is truly targeted to changing practitioner practice, their behaviors in practice, and to achieve changes in healthcare outcomes. The third recommendation is to utilize a model of improvement or a logic model A model of improvement or model of improvement is an IHI term, and it involves asking three questions. What are we trying to accomplish? How will we know there is improvement? In other words, how will we measure and determine if things have changed? And lastly, what changes can we implement that will lead to improvement? And it combines asking those questions with then implementing PDSA cycles to test those planned changes. You may be much more familiar with logic models, which lay out in detail the resources that one is going to apply, the actions that one will engage in, and how it is expected that those things will result in the changes that you desire to see. Recommendation 4 is to be guided by the evidence, but not paralyzed by it. As we looked at the learning collaborative literature, there are lots of ways in which to pick it apart, but we must, at the end of the day, find the best evidence available, make decisions about what is most likely to achieve the objectives that we have set forward. Recommendation 5, which was mentioned by Manny, is really to adopt health equity as a lens for everything that we do. And lastly, to measure impact. And the types of things that we saw measured in terms of learning collaboratives was satisfaction, practice change, healthcare outcomes, cost benefit analyses, and this all-important issue of sustainability. When we turn to looking at the recommendations specific to collaboratives, the first one would be to use an IHI BTS style collaborative model if there are clear evidence-based practices to promote, if there's sufficient resources to actually conduct a collaborative of that nature, and if there's sufficient provider interest and capacity to take advantage of that model and that opportunity. The next recommendation related specifically to collaboratives is to draw from the identified key elements, both from IHI and from the research studies who have tried to articulate the components, and to recognize that the farther one departs from those elements in that model, the less certain one is of the outcomes that one would achieve. If those conditions that are described above are not available, our recommendation is to consider variants of the Breakthrough Series model. And then moving on to emphasize the importance, again, of linking any kind of learning collaborative to some sort of sustainability structure and network, if at all possible, in order to promote the changes being maintained. We encourage you to build within your center's learning collaborative knowledge and the capacity to deliver collaboratives, which can either be done with your own staff or through partnerships with others. The concept of partnership comes up over and over again in the learning collaborative literature, both as a way in which to secure funding to launch collaboratives and as a way to assemble enough capacity and expertise to deliver them effectively. We recommend that you draw on the wealth of available learning collaborative resources. We've put together a separate resource guide that outlines all of the types of resources available at IHI. There are lots of different sort of manuals that have been prepared and guides by others. There's an online guide to running collaboratives that's been prepared in the child trauma area, and lots of quality articles and white papers that provide specific resources as well. And last but not least, we encourage you, if you conduct a learning collaborative, to document it in detail in terms of both what you did and what the outcomes were, in an effort to contribute to the knowledge base on collaboratives and their impact. Which brings us to sort of our final conclusion. There is no doubt that learning collaboratives are what one expert called a heavy lift. They take time, they take resources, but we would argue that some of our work must target changes in healthcare practice and healthcare outcomes, and that learning collaboratives are a very viable strategy for trying to tackle that agenda. It's clear that learning collaboratives are not for all agencies. Not all have the capacity to participate. But at the same time, we cannot simply leave behind the under-resourced safety net organizations, which are the organizations that are most likely serving the diverse populations. Which brings us to our sort of final conclusion, which is there is a need for action, which in this case would involve implementing learning collaboratives or other effective structures and processes that are currently available to us, and at the same time collectively advocating nationally for the resources that are necessary in behavioral health so that all agencies are capable of participating in effective quality improvement initiatives. So I'm going to stop there and turn it back to Heather to facilitate some discussion.
Excellent. Thank you, Michael and Manny. That was great. Love the summary and distillation of all the months of work that you have both done on this project. We certainly want to thank all of your key informants, many of whom came from recommendations from this group. So I think they were integral in this work as well. I'm going to kick off the questions with one that came through from Lydia Chwastiak. She's saying, did any experts share any insights about best strategies to increase engagement and participation? Our experience has been that participation is greater when an organization has paid for or made an investment in the learning collaborative.
Engagement and participation. So one of the recommendations, and I think Manny alluded to this, was to, in a sense, insist on participation from the get-go, to leave very little room for people not to be active participants. A practical way in which that plays out for any of the collaboratives that involved requiring an assembly of data, the people had to collect data, was to get them started on that within the first several weeks of the collaborative, and to insist on it being, people sticking with it. So that was one idea, and sometimes goes against our grain as mental health professionals, giving people slack, trying to understand the demands they're under. But I thought that particular recommendation was interesting. Another thing that would touch on that came from Dr. Davidson. So we were talking about the importance of in-person versus virtual meetings. And he recommended that in-person meetings were most essential when people were mandated to participate in the collaborative. So some collaboratives around the country are sponsored by states and they mandate agency participation. And we certainly know that in probably all collaboratives, some of the members of the teams are essentially mandated to participate. It may not be their choice. And so his sense was having an interpersonal connection and an in-person connection when possible, obviously not possible right at the moment given the pandemic, but that was the most important time to establish that those personal relationships to sort of carry that weight. At a larger level, out of the school-based mental health area, out of the supported employment area, the Johnson & Johnson, Dartmouth, now Rockville program works with states and brings a lot of money to them to support their involvement, but it requires them to put in a significant amount of money as well. They consider that essential to building commitment in that process. In a similar vein, they also require them to invest in building local talent to sustain the initiatives, as opposed to bringing in experts from outside their state as a strategy of sustainability. So a variety of sort of different kinds of perspectives on the issue of participation.
Other questions or discussion? Maria Restrepo-Toro.
Hi, this is
Hey,
Maria. Good to see you guys. I have a question about length. We go back and forth about whether it's a year, 9 months, does it make a difference? What's your advice?
So we interviewed a couple people from IHI, and some of the other experts. I mean, there is a sense that in general that a year is a very short period of time for people to, first of all, get organized, to decide what they're going to do, and to implement it and learn from what they're doing, and to get far enough down the line to actually sort of have impact. And so numbers of people talked about the importance of having 18 months to be able to adequately complete that cycle. There are some different situational issues. The work that's done in school-based mental health tends to focus on the cycle of a school year. The interventions being mainly during the 9 months, but the project may run for a year or so. So the context of where you're implementing the collaborative sort of has some impact. And then to the other extreme, it's not really an extreme, but it goes back to the point of sustainability. One of our experts said that the notion that we could do anything for 18 months and walk away is absurd. And her point was that there have to be structures of some sort to support and continue to sustain the gains that have been made. And it may be, if you look at what IPS does with its kind of combination of what's essentially a learning collaborative up front, but attachment to a learning community, that the collaboratives could be, the intensive collaboratives could be shorter if they're linked to an ongoing sustainability structure. The last thing I will say about that is Dr. Gustafson and also one other expert suggested that we may want to look to doing modular types of interventions where we focus on a type of change, that it's sort of shorter kind of process, but it's linked to multiple events like that, so that people can quickly see change in a narrower area, get some momentum, and then feel energized to move to sort of a next shorter type of piece. I haven't seen that model sort of fully developed, but it's another interesting idea that sort of, recognizes that time and money and attention spans may be short, and that may be another concept we could work with as we move forward in the evolution of these ideas to make them more palatable and affordable and effective.
Thank you.
That's really interesting. That last point, Michael, makes me think there's some work being done now in implementation science research on adaptive trials, right? It's trying to figure out some centers or organizations are like ready to change, they're able to change, they're more nimble, and so they need just a little bit of help to move forward and implement something, whereas other agencies or organizations need a lot of help, a lot of support, a lot of hand-holding, coaching, more intensive things, and it's hard to know what you're dealing with. So adaptive trials are trying to figure out how to distinguish between those two, or maybe there's 3 or 4 other kind of groups like that. So I'm thinking about that modularized approach to learning collaboratives, or even just to the training and technical assistance that we provide. Is there a way to set things up so that everyone gets a little bit, and then you kind of see which organizations need more? It'd be a really interesting way to think about it.
It also speaks to this dilemma in our field, which people talk about. So many behavioral health organizations are stretched and stressed, and it's very difficult for them to take on, additional projects. But the dilemma is, if we scale back on the interventions to improve quality to the point where they're more palatable, they're easier to sort of manage for an organization, but perhaps not effective or not anywhere as effective, that's sort of the dilemma. And that gets back to sort of there being adequate resources so that our organizations can effectively, focus on improving quality.
Alfredo has a great comment here in the chat. We at Region 5 have found that engaging agencies in gathering baseline data, like pre-collaborative coaching, prior to the start of the collaborative is proven to help participation and sustainability. So that pre-work piece that you have folks do before they actually begin.
One of the things that I actually was very surprised at, even in sort of the general healthcare area, is the collection of data is a major problem, and getting organizations to understand how to implement a change and measure it is a real challenge. So the concept of, let's plan, do, study, act seems really simple, but um, and we speak about this in the review, and there's a link in a review to a nice article. I think it's called something like "What's the Problem with PDSA Cycles" or something, but it talks about all the ways in which you can fail in that process. You might plan and you might implement, but there's not much studying that's done. Sometimes the plans are not very effective. So, but kind of that notion of extra help with agencies to understand data, to gather data, I would agree is really essential. That's why you see with some of these larger initiatives, like in the child trauma area and in school mental health, we've created these online platforms and simple tools for people to input their data, and it gives them back dashboards and reports, which I think has sort of greatly facilitated their ability to work with these issues.
Other questions? Lydia?
Yeah, it's actually more of a comment, just thinking about your comments, Heather, about the heterogeneity of organizations that come into cohorts, and thinking about, sort of thinking about how our work what we might learn from our work as TTCs and move this forward about how to address heterogeneity in terms of resources, data tracking capacities, QI experience. I mean, if the organizations aren't all starting in the same place and are being asked to do these multiple tasks, just kind of thinking about, is there a threshold for involvement, or, can you stage participation in a collaborative, or cohort the collaboratives? That all takes resources, but it can be very inefficient if organizations are in very different places. You're sort of, not serving anyone well if you've got some middle ground, and that's the really challenging practical issues.
I think there's some truth to that, but I think Manny alluded to one recommendation, which is, to work with the variability and to have, agencies sort of help each other. The other thing is, in my experience with collaboratives, you're bringing the evidence base, the possible interventions, and then each agency develops their own particular plan. And then in a lot of collaboratives, the technical assistance that occurs is really sort of individualized in between those sessions. So I think there is something about the structure that allows you to work with people who are in different places. We run a collaborative on recruitment and retention. And, I launched one in Ohio last year, and one of the agencies that showed up had 900 employees, and the agency at the other end of the spectrum had 4. And I was a little shocked. I'd never worked with one that had 900. I had never worked with one that had 4. But it is a process that I think has still been very productive for both organizations. They have different struggles and have to approach things in different ways. But the process of them learning together about strategies and sharing sort of what they're doing sort of still occurs despite their very different sort of places in that universe.
And if I may say also, hi Lydia, how are you? Good to see you.
Nice to see you, Manny.
Thank you. In the collaboratives that Michael and I are working on, it's been amazing to see. As an example, let's say virtual platforms. Some agencies were very far along on having virtual capabilities, and others were not. Electronic medical records was another one. And there were several issues that came up where some agencies were doing a lot better and much farther along than others. And it was wonderful to see the agencies supporting each other. We put a call out, for assistance on, we have an agency struggling with X, and then all the feedback that would come in from other agencies. And they've been able to kind of move the dial on these various issues that they've been struggling with as a result of all the assistance and support that they've gotten from the collaboratives. So some of that actually just happens organically as well. And it's been really, really nice to see how cooperative agencies have been in supporting and helping each other, particularly now with the pandemic and all the struggles that agencies are facing. They've really banded together and helped each other out tremendously.
Yeah, we've had similar experience. It's great to hear that that's your experience. I guess I'm thinking back to, as part of our Medicaid transformation activities in Washington State, we had learning collaboratives of groups of behavioral health organizations to integrate health monitoring, physical health tracking, and just those agencies that couldn't even track data were really, it was hard for them to participate and really trying to problem solve in a way that, you know, troubleshoot with individuals. I mean, sort of beyond tailoring the TA, where it's an extreme version of tailoring the TA, but it's the best part of the learning collaboratives when everybody learns from each other, and that organizations really, somebody has something to share and help others. It can be very powerful.
But and to your point, I mean, some of the organizations in our field are so small or have so few resources, they have very little infrastructure on which to rely to actually make changes. And so that, I mean, it is a huge problem in terms of how far some of the agencies can go. I think all of them, if they have some motivation, can move farther forward from where they are. But for some of the things like you're talking about, you know, you have personnel limitations and data system limitations. There's just only so much you can do.
And I can say just one more thing, and this is to Lydia, a question that you posed before, and to Maria as well, that posed this question around sustainability and so forth, is the leadership buy-in. And having leadership participation. There has to be skin in the game in order for implementation to occur and for sustainability to occur as well. If the leadership takes a hands-off approach on the collaborative, then in my opinion, at least, it doesn't seem that it's going to work out as well. But if leadership is involved, if they're ideally they're actively involved to the extent that they can, I think that's where the collaborative really, really thrives. It shows the other team members that there's a commitment in the agency to the collaborative, and it can be either through intellectual resources or financial resources, but having leadership really involved and with them working on whatever tasks they're working on, I have found that to work really well and really motivates the rest of the team.
We've had collaboratives where a CEO picks a team, the team comes to the collaborative, and the team thinks that the CEO or his team, the leadership team, is the problem in the organization. And Dr. Gustafson argued that for collaboratives in general, one of the problems is that sometimes it's the teams are setting the priorities as opposed to the senior leadership of the organization. And that if the organization's going to function, you know, he argues this would never happen in business, right? The top leadership would set the direction and the team would be there to achieve the senior team's, you know, sort of goals. So just another dimension of the importance of there being some connection and synchronicity between the senior leadership and the team that might be participating in the collaborative to bring about, you know, to plan the changes, to set the goals and implement the strategies.
Great discussion. We're about at the top of the hour, so we'll wrap up now. Thank you again, Michael and Manny, for your amazing hard work. This is really going to be a benefit, I think, across the TTC networks. Thanks everyone for attending. The report and the resource document and soon this webinar will all be up on the website. We'll send out an email when those are all posted. And we appreciate your participation. Thanks everyone. Have a great rest of your week.
And Heather, to you, our thanks for supporting this project and for your contributions to the intellectual backbone of it. Thank you so much.
Excellent.
Thank you, everyone. Take care.
Bye, guys.
Bye-bye. Bye, Maria. Bye, Alfredo.
I call you.
Okay, Maria, we'll talk.